Okay, let's dive in. Your kidneys, those unsung heroes inside you, they filter an astonishing amount of blood plasma every single day. We're talking around 900 liters.
Wow, 900 liters. It's hard to even picture that.
Right. It's like the entire volume of, I don't know, a small swimming pool getting processed. And after all that work, they reclaim almost all of it, leaving you with just, well, about a bottle and a half of urine. Pretty wild, isn't it?
It really is. And it highlights just how crucial they are for keeping everything balanced, which is what we're getting into today.
Exactly. And what's fascinating is how this constant filtering and refining directly links to our overall well-being and maybe especially to the health of our blood vessels.
That connection is key,
Yeah.
particularly how vascular health and kidney health interact.
Yes. So today we're taking a deep dive into how your kidneys function and importantly, how procedures on your blood vessels, things like surgery or those less invasive endovascular treatments, how they can sometimes impact these really vital organs.
hmm Our source material for this is the well-known textbook Rutherford's Vascular Surgery and Endovascular Therapy, a really authoritative source.
Definitely. Think of us as your guides through these expert-level insights.
And understanding this connection is really important, especially if you or someone you know might be facing or recovering from any kind of vascular intervention.
So we'll start with a look at the basic structure, the nuts and bolts and the incredible daily work of the kidneys. Then we'll focus specifically on the potential complications that can pop up after these vascular procedures.
Right.
Our mission, really, is to pull out the most important knowledge from these medical chapters and give you a clear picture of what's going on without getting totally lost in, overly complex medical jargon.
So what's the kidney's secret? How does it manage all that work so efficiently?
Well, structurally, the kidney is it's a marvel of miniaturization, really. It's packed with about 1 million tiny filtering units called nephrons in each kidney.
A million each.
Yeah. Think of each nephron like a microscopic water treatment plant. It's got these intricate loop, some short, some long, called the loops of Henle, and then collecting ducts.
Okay.
And all of this is supported by this super fine network of blood vessels, the microvasculature. It's like a city's entire plumbing system shrunk down basically to the size of your fist.
And what's really clever structurally is this process called countercurrent exchange. Happens in the kidney's inner part, the medulla.
Countercurrent exchange. Okay.
Yeah. Imagine two pipes running side by side, but the fluid in them flows in opposite directions. This setup lets the kidney create this concentration difference, an osmotic gradient.
Ah, okay.
And that helps it precisely control how much water our body holds onto.
Hmm.
It's like a super efficient way of squeezing every last useful drop of water out when we need it.
So it's a highly specialized recycling system for water, kind of. And this is all made possible by those tiny blood vessels keeping things separate in different zones within the kidney. Now, okay, that's the structure. How does this amazing microscopic plumbing actually do its job day to day?
Well, the kidney has three main jobs, functionally speaking: filtering, secreting, and reabsorbing.
Okay, filter, secrete, reabsorb.
Yep. First, in these structures called glomeruli, think of them as the initial strainers. About 20% of the blood's fluid, the plasma that passes through the kidneys, gets filtered out.
Right, that's the start of that huge 900-liter volume processing.
Precisely. Then, as this filtered fluid, now called filtrate, travels through these long, winding tubules, the kidney selectively adds some waste substances to it, that's secretion.
Okay.
And, more importantly, it reclaims the vast majority, around 99%, back into the bloodstream. That's reabsorption.
99%. That's some serious resource management.
Absolutely. It has to be incredibly efficient. And those loops of Henle we mentioned, they're crucial here. The descending part of the loop lets water leave the filtrate, moving out into the kidney tissue. But the ascending part actively pumps out salt, sodium, and chloride.
Ah, okay, so water out, then salt out.
Right. And this action creates that difference in salt concentration in the kidney's inner core, the medulla. It makes it really salty down there.
Which then helps pull water back into the body later on.
Exactly. It sets up the gradient needed for concentrating the urine and reabsorbing water efficiently.
I get it. It's like the kidney creates this salty environment that encourages water to move back where it's needed. Makes sense. And then hormones like aldosterone step in to fine-tune things, right?
Precisely.
Yeah.
Aldosterone, which acts mainly in the later parts of the tubules and the collecting ducts, it's like a gatekeeper for sodium.
Okay.
Does the kidney cells reabsorb more sodium? And because water tends to follow salt,
It helps retain water, too.
exactly. In the end, only a tiny fraction, we're talking less than 1%, maybe 0.2 to 0.8% of all the sodium that was initially filtered actually leaves in our urine. Potassium, another important electrolyte, is also mostly reabsorbed, mainly in the earlier parts of the tubules, like the proximal tubule and the thick ascending limb.
Okay, so the kidneys are the ultimate fluid and electrolyte regulators. But what tells them when to conserve and when to let go? It's not like they have a little brain making these decisions second by second.
No, they don't. That's where the body's communication network comes in the neuroendocrine system and also local signals called paracrine signals.
Okay.
We have pressure sensors called baroreceptors located in our major arteries and also in the atria of the heart. They constantly monitor blood pressure and blood volume.
Like little spies checking the pressure.
Kind of, yeah. If these sensors detect a drop, say, if you're dehydrated or losing blood, they send signals through the nervous system. And these signals trigger responses designed to make the body hold on to more salt and water, ultimately helping to bring the pressure back up.
So if your blood pressure dips a bit, these sensors tell the kidneys, okay, time to go into conservation mode. Makes perfect sense.
Exactly.
And what about this RAAS system I've heard about, the renin-angiotensin-aldosterone system? That sounds like a major player.
Oh, it absolutely is. A key player in long-term blood pressure and volume regulation. When the kidneys themselves sense a drop in blood pressure in the artery going into the glomerulus, or if they detect less salt arriving at a specific sensing point called the macula densa,
The macula densa, okay.
or even through direct stimulation by the sympathetic nervous system, they release an enzyme called renin.
Renin, that's the start of the chain reaction.
That's the first domino. Renin converts a protein already in the blood into angiotensin VI. Then another enzyme, ACE angiotensin converting enzyme.
Ah, the target of ACE inhibitors for blood pressure.
Exactly that one. ACE converts angiotensin I into the really active hormone, angiotensin II.
And angiotensin II is often thought of as just something that constricts blood vessels and raises blood pressure, right?
It definitely does that. It's a potent vasoconstrictor, which directly increases blood pressure and actually reduces overall blood flow to the kidneys a bit. But it does more. It also directly signals the kidney tubules to reabsorb more sodium. And importantly, it stimulates the adrenal glands to release aldosterone.
The sodium gatekeeper we just talked about.
The very same. So angiotensin II triggers multiple actions: vasoconstriction, direct sodium reabsorption, and aldosterone release, all aimed at increasing blood pressure and restoring fluid volume. It's like the body's emergency response team for low-pressure situations.
Okay, so it's not just a simple villain causing high blood pressure. It's a complex system trying to restore balance when things drop too low.
Precisely. It's essential for survival, but obviously if it's overactive, it can contribute to chronic high blood pressure.
Right. What about these other things mentioned in the text? Eicosanoids and nitric oxide. They sound like they're also involved in this balancing act?
They are indeed. They often act as counter-regulators within the kidney. Eicosanoids, which include certain prostaglandins like PGE2 and PGI2, generally act as local vasodilators within the kidney.
So they relax the blood vessels.
Yeah, think of them as helping to keep the kidney.
So also helping to keep things open and flowing.
Right. And it seems that if nitric oxide production is reduced, perhaps after an injury, it can contribute to more vasoconstriction within the kidney. There might even be a link between nitric oxide and the regulation of that COX2 enzyme we just discussed.
Wow, it's like there's this constant, complex internal dialogue happening within the kidney constrictors versus dilators, all to keep everything running smoothly.
Precisely. It's a dynamic equilibrium. And there are other players too. We have atrial natriuretic peptide, or ANP.
ANP from the heart.
Yes, released by the heart's atria, usually when blood volume gets too high, stretching the atrial walls. ANP generally has effects opposite to the RAAS system.
So it makes you lose salt and water.
Correct. It promotes sodium excretion by the kidneys, can increase the initial filtering rate, the GFR, and it also suppresses the release of both renin and aldosterone. It's trying to lower blood volume and pressure.
Okay, so ANP is like the RAS system's counterpart for high-volume states.
In many ways, yes. Then we also have substances called endophyllins, which are produced locally in the kidney and are generally potent vasoconstrictors. And there are other local signals too, like purines, things like ATP and adenosine and even uric acid, that can influence blood flow and reabsorption within the kidney in more subtle ways.
So it's this incredibly complex orchestra of hormones arriving via the blood and local signals produced right there in the kidney, all working together, sometimes opposing each other, to keep our internal fluid environment just right.
That's a great way to put it, an orchestra maintaining equilibrium.
Now, with this incredibly delicate system, this fine-tuned orchestra, what happens when someone undergoes a major vascular procedure? How can that potentially disrupt this balance?
Well, that's where we can run into problems. Renal dysfunction, kidney problems, after vascular procedures can really vary. It can range from relatively minor changes in how the kidney handles salt and water, all the way up to serious acute kidney injury or AKI, sometimes even acute renal failure. And while advances in surgical techniques and the newer endovascular methods have definitely reduced how often severe complications happen, they still occur, and when they do, they unfortunately carry a significant risk of, well, mortality.
Right, serious consequences.
So we generally categorize these issues into three main types, based on where the problem originates relative to the kidney itself. We talk about prerenal, renal, which is also called parenchymal, and postrenal causes.
Okay, three categories. Prerenal, that sounds like something affecting the blood supply before it even gets to the kidneys, right? Like upstream.
Exactly, that's the idea. And this is the most frequent cause of kidney problems, especially early on after surgery. The most common reason is simply not enough fluid volume in the body, hypovolemia.
Dehydration, essentially.
Or maybe reduced performance from the heart, so the cardiac output is low. In either case, the effective blood flow reaching the kidneys is reduced.
And the body's compensation kicks in.
Right. Those neurohormonal reflexes we talked about, like the RAAS system, sympathetic nerves, they get activated trying to conserve salt and water.
But in vascular surgery patients who often have underlying heart issues.
Exactly. It can be really challenging sometimes to tell if the reduced kidney function is just due to needing more fluids, or if it's because the heart isn't pumping strongly enough. Doctors might have to carefully give a bolus of fluids while maybe also using medications to support the heart and then watch the urine output closely. It can be both a diagnostic test and a treatment approach.
That makes sense. A cautious approach is needed. You wouldn't want to overload someone with fluids if their heart isn't strong enough to handle it. The text also mentioned ischemic nephropathy as a prerenal cause.
Yes, that's another type of prerenal problem. This refers to reduced kidney function, specifically because of a narrowing or blockage in the renal arteries themselves, the main arteries supplying the kidneys.
So the problem is in the renal artery, but before the kidney tissue.
Correct. If other prerenal causes like simple dehydration or heart failure seem unlikely, doctors might use a special ultrasound, a duplex sonography, to look directly at the renal arteries for significant blockages. And if that's concerning, they might need to do an angiogram for a more detailed look.
Okay, so prerenal issues are about what's happening upstream of the kidney, affecting its blood supply.
Yeah.
Postrenal problems, then, I'm guessing that's blockages downstream, preventing urine from getting out?
You got it. Postrenal obstruction. This is actually the least common cause of suddenly decreased urine output, or oliguria, after surgery. Usually the blockage is at the level of the urethra, that's the tube carrying urine out from the bladder, or maybe an issue with the urinary catheter itself if the patient has one in.
Like a kink or a clot in the catheter.
Exactly. Simple things like blood clots or kinks in the catheter are common culprits. Less frequently, you might get a blockage higher up, in the ureters, the tubes connecting the kidneys to the bladder, or even within the collecting system, inside the kidney, the renal pelvis.
Could that happen during surgery?
It could, yeah. An accidental injury during complex aortic surgery, or maybe the placement of a graft could compress a ureter, or even underlying kidney stones causing a blockage. Ultrasound or kidney scan called renography might give the first clues, and then a procedure called retrograde urography, where dye is injected backwards up the ureters, can usually confirm the diagnosis and location of the blockage.
Okay, and one other thing mentioned was acute urinary retention after the catheter comes out.
Right. Sometimes after surgery, especially if epidural anesthesia was used, or in men with underlying prostate enlargement, the bladder might have trouble emptying properly once the catheter is removed. That's another form of postrenal issue.
Okay, so postrenal is basically a plumbing problem in the outflow system, which leaves us with the middle category, renal or parenchymal causes. This is where the damage is directly to the kidney tissue itself, right? And that's where acute tubular necrosis, ATN, comes in. That sounds pretty serious.
It is. ATN represents damage to the actual filtering tubules of the kidney, and it definitely poses the greatest risk for significant, potentially permanent kidney failure.
What actually happens to the cells in ATN?
The fundamental problem is often a lack of oxygen and energy, ATP, within the cells of the kidney tubules. This energy shortage leads to a cascade of problems. The cell's internal structure, the cytoskeleton, breaks down. The cell loses its normal orientation and connection to its neighbors. The tight junctions between cells become leaky, and eventually cells can actually die and slough off, shedding into the tubule.
And clogging things up.
Exactly. These shed cells and debris can form casts that physically block the tubules, which further worsens kidney function. Clinically, what we usually see is an abrupt rise in the serum creatinine level. That's a key waste product cleared by the kidneys, sometimes with, sometimes without, a noticeable drop in urine output. And if you look at the urine under a microscope, you might actually see these damaged tubular cells or casts.
And the main causes in the context of vascular surgery.
The two big ones are ischemic injury, meaning lack of blood flow, and toxic injury, from exposure to substances harmful to the kidney cells.
Ischemic injury that makes intuitive sense with vascular procedures where blood flow can be temporarily interrupted or reduced.
Right. Acute ischemic renal injury can happen if there's a temporary, complete stop in blood flow to the kidneys, like during aortic clamping above the renal arteries, or even just a period of severe low blood pressure throughout the body. Systemic hypoperfusion.
And the damage isn't just from the lack of oxygen, is it?
No, the reperfusion phase, when blood flow returns, can also cause damage. It's a bit of a double whammy. First, after blood flow is restored, the tubular cells can swell up, which can physically obstruct the flow of filtrate inside the tubule. Second, the lack of oxygen can damage the connections holding the cells to their underlying basement membrane or cause outright cell death. This leads to gaps, allowing the filtered fluid to leak back out of the tubule into the surrounding tissue instead of continuing on to become urine.
So leakage and blockage, are some parts of the tubule more vulnerable?
Yes. The medullary thick ascending loop of Henle, that salt pumping segment we talked about, and a part of the proximal tubule called the pars recta, seem to be particularly sensitive to ischemic injury.
And the highest risk procedures are?
Definitely major aortic surgery, especially when the clamp has to be placed above the renal arteries. But other situations can cause acute ischemic injury too. For instance, a sudden blockage of a main renal artery, often from a blood clot that traveled from the heart, like an atrial fibrillation.
That must be hard to diagnose quickly.
It can be, especially if the patient has other reasons for being unwell. How well the kidney recovers depends heavily on how long the artery was blocked and whether there are any collateral blood vessels providing some alternative flow.
What else causes ischemic injury?
A tear in the wall of a renal artery, a dissection, can disrupt flow. And then there's atheroembolism.
Atheroembolism, that's the cholesterol crystals breaking off.
Exactly. Small cholesterol crystals, or fragments of plaque, breaking off from diseased areas in larger arteries, like the aorta, and lodging in the tiny arterioles within the kidneys. This is being recognized more and more as a cause of acute kidney injury, particularly after procedures involving manipulation of the aorta or renal arteries, like angiography or stenting. Sometimes it happens spontaneously.
And it can be serious.
It can be very serious, sometimes leading to irreversible kidney damage and the need for dialysis. Clinically, you might suspect it if kidney function worsens after a procedure, and especially if there are other signs, like small purplish spots on the skin, levato reticularis, or maybe the blue toe syndrome, along with perhaps a rise in a specific type of white blood cell called eosinophils.
How is it diagnosed and treated?
Definitive diagnosis usually requires a kidney biopsy to see the cholesterol crystals lodged in the small vessels. Unfortunately, treatment is mainly supportive, managing blood pressure, fluids, and dealing with complications. There's no specific way to remove the crystals once they're there.
And beyond these direct vascular events?
Sepsis, severe heart dysfunction after surgery, and the general inflammatory response to major surgery and reperfusion injury can all contribute to kidney dysfunction, sometimes temporary, sometimes more permanent.
Okay, so that covers the acute lack of blood flow. What about when the blood flow reduction is more gradual, more chronic?
That leads to what's called chronic ischemic nephropathy. This is a progressive decline in kidney function, specifically caused by long-term reduced blood flow, usually due to significant narrowing stenosis in both renal arteries or in the arteries supplying a single functioning kidney.
And this is different from acute injury.
Yes, it's a slower process, but it can be quite rapidly progressive once it starts. Unfortunately, a significant proportion of patients with ischemic nephropathy, maybe up to 20%, eventually become dependent on the dialysis. It's also associated with high mortality if it's not corrected.
When would doctors suspect this?
They typically investigate for it in patients who have worsening kidney function, as especially if they also have difficult to control high blood pressure, or if their kidney function gets significantly worse when they start taking an ACE inhibitor or an ARB medication.
Why do those drugs worsen it?
Because in a kidney relying on high pressure to force blood through a narrowed artery, angiotensin desac actually helps maintain the filtration pressure within the glomerulus.
Hmm.
Blocking angiotensin desac with an ACE inhibitor or ARB can cause a sudden drop in that filtration pressure, leading to a decline in kidney function.
Okay, that makes sense.
The hypertension of these patients tends to be very severe and often volume dependent, meaning it's exacerbated by fluid overload. They might present with episodes of sudden fluid buildup in the lungs, called flash pulmonary edema. It often coexists with other types of intrinsic kidney disease too, making diagnosis complex.
Okay, so that's ischemic injury, both acute and chronic. What about the other major cause of ATN toxic injury? You mentioned antibiotics and contrast dye.
Right. Common nephrotoxins, substances poisonous to the kidneys encountered in the hospital, include certain antibiotics, particularly the aminoglycosides like gentamicin.
How do they cause damage?
They seem to damage the mitochondria within the tubular cells, disrupt cell membranes, activate enzymes that break down cell components, and alter lysosomes. The risk is higher in people who already have some kidney insufficiency, are older, dehydrated, or are receiving other potentially nephrotoxic drugs at the same time.
Can monitoring drug levels prevent this?
Routine monitoring of blood levels doesn't necessarily prevent the toxicity, unfortunately. Their use has decreased somewhat as alternative antibiotics have become available, but they're still used.
What about myoglobin for muscle damage?
Yes, myoglobinuria. Myoglobin is a protein released from damaged muscle tissue, which can happen after prolonged ischemia to a limb, for example, followed by revascularization. This released myoglobin gets filtered by the kidneys, but can be directly toxic to the tubules and can also form casts that obstruct them.
How would you know if that's happening?
A key clue after reperfusion of an ischemic limb might be urine that looks reddish or brown. A urine dipstick test will be positive for blood, but when you look under the microscope, you won't see many red blood cells. Confirmation comes from a specific urine test for myoglobin.
And the treatment?
The main treatment is aggressive hydration with intravenous fluids to try and flush the myoglobin through the kidneys and maintain a high urine flow. Using osmotic diuretics like mannitol and sometimes alkalinizing the urine with bicarbonate might also help prevent the myoglobin from precipitating in the tubules.
Okay. And then the big one, contrast media, contrast-induced nephropathy, or CMIN. I know that's a major concern whenever contrast dyes are used for imaging.
It absolutely is. CMIN accounts for a significant percentage, maybe more than 10%, of all cases of hospital-acquired acute kidney injury. And it's associated with increased mortality and healthcare costs, so it's a big deal.
Do the newer contrast agents carry less risk?
The newer non-ionic contrast agents are generally considered less directly toxic than the older ionic ones, but they still definitely carry a risk of causing CMIN. The primary site of injury seems to be the renal tubule, likely resulting from a temporary period of reduced blood flow and oxygen supply within specific regions of the kidney, possibly combined with some direct cellular toxicity.
Who is most at risk for CMIN?
The biggest risk factor by far is pre-existing renal insufficiency, having chronic kidney disease already. That increases the risk several-fold. Other major risk factors include diabetes, especially type 1, dehydration, receiving a large volume of contrast dye, concurrent use of other nephrotoxic drugs, and conditions like multiple myeloma or significant protein in the urine.
What's the actual incidence?
It varies depending on the patient population and how it's defined, but after angiography, it might range from essentially 0 in people with normal kidney function up to 12%, or even higher in high-risk groups. People with diabetes who develop CMIN also tend to recover kidney function less often and have a higher risk of needing permanent dialysis.
Are the exact biochemical mechanisms understood?
Not completely. It's complex. There's thought to be a role for altered balance between vasoconstrictors and vasodilators within the kidney. For example, nitric oxide and those vasodilating prostaglandins we discussed normally help maintain blood flow. Some studies suggest contrast media might actually suppress the production of nitric oxide.
So what can be done to try and prevent or manage CMIN? This seems critical.
It is. The absolute cornerstone of prevention is ensuring the patient is well hydrated before, during, and after the contrast exposure. Giving intravenous fluids, usually isotonic saline, to maximize urine flow is key.
Saline is preferred.
Generally, yes. Some studies have looked at adding mannitol or furosemide to the saline, but saline hydration alone seems to be the standard. There's also some evidence that hydrating with a solution containing sodium bicarbonate instead of plain saline might be beneficial, possibly by reducing the formation of damaging free radicals.
What about the amount of contrast? Is there a safe limit?
There's no definite safe upper limit that applies to everyone. Even small doses can be risky in someone with very severe kidney insufficiency. Conversely, some patients with a relatively normal function might tolerate over 300 millibells without problems. But as a general rule, it's prudent to try to limit the volume of non-ionic contrast, especially in patients with significantly reduced kidney function, say a GFR less than 20 or 30 millimillim, and maybe keeping it under 50-75 millimils if possible.
Are there alternatives to standard contrast?
Yes, depending on the clinical situation. Digital subtraction angiography can sometimes allow imaging with less contrast. Carbon dioxide gas can be used as a contrast agent, particularly for imaging below the diaphragm. It avoids iodine exposure but does carry risks of other non-renal complications like pain or nausea and potentially gas embolism. Ultrasound with Doppler can be very useful for assessing blood flow. Gadolinium-based contrast agents used for MRI are generally not recommended as an alternative in patients with compromised renal function because of the risk of a serious condition called nephrogenic systemic fibrosis.
What about medications? I've heard about N-acetylcysteine.
N-acetylcysteine, or NAC, is an antioxidant. There have been many studies looking at whether giving it orally or IV around the time of contrast exposure can protect the kidneys. The evidence is quite conflicting, though. Some meta-analyses suggest a possible benefit, while others show no effect. Its routine use remains controversial, but it's sometimes given, especially in higher-risk patients, because it's relatively safe.
Any other medication adjustments?
Yes, it's generally recommended to hold certain medications for about 72 hours before contrast exposure if possible, particularly high-dose loop diuretics, ACE inhibitors, and ARBs, as these can potentially worsen kidney injury in this setting. If blood pressure control is needed, other agents like beta blockers or calcium channel blockers can be substituted. There's also some emerging evidence that statins might have a protective effect against CMIN, but more research is needed.
What about dialysis right after the procedure to remove the contrast?
Peri-procedural hemodialysis, or hemofiltration specifically, to remove contrast, hasn't generally been shown to be effective in preventing CMIN and carries its own risks, so it's not typically recommended for this purpose.
Okay, so hydration, minimizing contrast volume, considering alternatives, and careful medication management are the mainstays.
Pretty much. And ongoing research is looking at other potential strategies like remote ischemic preconditioning, briefly restricting blood flow in a limb to trigger protective mechanisms. But the data isn't strong enough yet for routine use.
Now, let's shift focus specifically to aortic surgery again. This seems like a particularly high-risk scenario for the kidneys. How does the surgery itself impact kidney function beyond the general risks of ischemia and contrast we've discussed?
Aortic surgery, especially major open repairs of the abdominal or thoracoabdominal aorta, causes significant physiological stress and fluid shifts within the body.
Fluid shifts. How so?
Well, there's the trauma of the surgery itself, the hemodynamic changes that happen when the aorta is clamped and then unclamped, and of course blood loss. All these things cause fluid to move out of the bloodstream, the intravascular space, and into the surrounding tissues, the interstitium. This is often called third spacing.
Why does the fluid move out like that?
Several reasons. Normally there's a balance. Fluid moves out of capillaries at the beginning due to blood pressure, hydrostatic pressure, and moves back in further down due to proteins like albumin in the blood pulling it back, oncotic pressure. Any excess fluid and protein in the tissues is normally cleared by the lymphatic system.
But surgery disrupts this.
Yes, aortic surgery can directly disrupt lymphatic channels. More importantly, the surgical trauma and periods of ischemia triggers a significant inflammatory response, releasing substances that make the capillary walls more leaky, especially to albumin.
So albumin leaks out of the blood vessels.
Right. When albumin leaks into the interstitium, it reduces the oncotic pressure gradient, pulling fluid back into the capillaries. This leads to less fluid reabsorption and more fluid accumulating in the tissues. This fluid shift activates those neuroendocrine mechanisms we talked about earlier, causing the kidneys to retain sodium and water, trying to maintain blood volume, but this can worsen the tissue edema.
And there's also fluid moving into cells.
Yes, particularly after periods of ischemia and reperfusion, like during aortic clamping. The normal energy-dependent pumps that keep sodium out of cells and potassium in the Na plus K plus ATPase can become impaired. This leads to sodium and water moving into the cells, causing them to swell. This shift of water into the intracellular space further depletes the circulating blood volume. Effective resuscitation helps reverse this cellular shift.
So the net effect is a significant loss of fluid from the effective circulating volume into this third space, the interstitium and the cells.
Exactly. It's driven by temporary ischemia, inflammation, acid-base shifts, unreplaced blood loss, potentially reduced heart and kidney performance during clamping, and the release of stress hormones. Managing fluids intraoperatively and in the early postoperative period is therefore critical, often requiring large volumes of balanced salt solutions to replenish the intravascular volume.
But this third space fluid eventually comes back, right?
It does, but usually not for several days, typically starting around postoperative day 2 to 5. This mobilization of third space fluid back into the circulation needs to be anticipated. If intravenous fluid administration isn't reduced accordingly, or if diuretics aren't used, this returning fluid can suddenly overload the circulation, potentially leading to volume overload and heart failure, especially in patients with limited cardiac reserve.
It sounds like a really delicate tightrope walk managing fluid balance around major aortic surgery.
It absolutely is. Careful monitoring is key.
What about the direct risk of kidney failure during the surgery itself? You mentioned clamping above the renal arteries is particularly risky.
Yes, suprarenal cross-clamping, especially during surgery for complex thoracoabdominal aortic aneurysms, TAAAs, poses a significant ischemic risk to the kidneys. Reported rates of acute renal failure requiring dialysis after elective TAAA repairs have been as high as 18% in some series.
And recovery depends on.
How well the kidneys recover depends heavily on the patient's kidney function before the surgery, their age, and critically, the duration of the warm ischemia time, how long the kidneys were without blood flow. Other factors like episodes of low blood pressure, heart problems, or sepsis also contribute significantly.
What about surgery below the renal arteries for infrarenal aneurysms? Is the risk lower?
The risk is generally lower than with suprarenal clamping, but it's definitely not zero. Rates of renal failure after infrarenal aneurysm repair are typically reported in the range of 1% to 13%. But even if kidney failure occurs in isolation after infrarenal repair, the mortality rate can be quite high, maybe 25% if urine output is maintained, non-oliguric, but up to 70% if urine output drops significantly, oliguric.
And if other organs fail too?
If kidney failure is part of multiple system organ failure after aortic surgery, the mortality rate unfortunately approaches 100%. The exact cascade leading to multi-organ failure is complex and not fully understood, but inflammation likely plays a major role.
What are the most common triggers for acute kidney problems right around the time of aortic surgery?
Temporary isolated renal ischemia from suprarenal clamping is a major one. Direct occlusion or injury to a renal artery is another. Systemic problems like severe low blood pressure from blood loss, hypovolemic shock, a sudden drop in pressure after the aortic clamp is released, post-clamp hypotension, or the heart failing to pump effectively, cardiogenic shock, are also common culprits. And as we discussed, atheroembolism from manipulating a diseased aorta is an important cause too. Even minor showers of emboli can tip someone with minimal renal reserve into acute renal failure.
It seems the level of aortic repair is a key factor.
It is. The incidence of acute renal failure definitely correlates with how high up the aorta the repair is needed. Thoracoabdominal repairs carry the highest risk. Some studies looking specifically at TAAA repairs found that having a preoperative creatinine level above 1.5 mg/dL and having an aortic cross-clamp time longer than 100 minutes were significant predictors of postoperative renal dysfunction. Interestingly, various surgical techniques used for TAA repair, like simple clamp and sew versus using adjuncts like regional cooling or bypass circuits, haven't consistently shown major differences in renal outcomes.
Does cooling the kidneys help?
Renal hypothermia, actively cooling the kidneys during the ischemic period, is thought to enhance preservation, particularly in repairs involving the aorta right near or above the renal arteries, juxtarenal or suprarenal AAAs.
And pre-existing kidney function is always a factor.
Absolutely. Even for infrarenal repairs, having reduced kidney function beforehand, say a creatinine clearance less than 45 millimol, is associated with a significantly increased risk of postoperative problems. One study showed no patients needed dialysis after infrarenal repair if their pre-op creatinine was normal, but 8% needed it if their creatinine was elevated above 1.8 mg/dL.
Okay, that covers open surgery. What about endovascular aneurysm repair, EVA? Is that generally gentler on the kidneys?
EVAR is less invasive overall, which is a major advantage. However, it's also associated with a risk of increased renal dysfunction. It's not risk-free for the kidneys.
How can EVR cause kidney problems?
Several ways. The devices used often require fixation above the aneurysm, sometimes near or even covering the renal arteries, suprarenal fixation. This can cause direct trauma to the renal arteries.
Awesome.
Manipulation of the device during positioning or if adjustments are needed can potentially cause dissection or injury to the artery walls.
Contrast dye is used too, right?
Yes, significant amounts of contrast dye are typically used during EVAR procedures, so CMIN is definitely a risk, just as with diagnostic angiography. Interestingly, though, some large analyses of EVAR patients haven't found a strong correlation between the volume of contrast used and the risk of postoperative kidney dysfunction in this specific setting, suggesting other factors might be more dominant.
Are there also longer-term kidney issues after EVAR?
Yes, that's been observed too. Some patients show a decline in kidney function during long-term follow-up after EVAR, sometimes for reasons that aren't entirely clear. It might be related to ongoing disease progression or perhaps subtle effects of the endograft itself.
So what do the data show regarding AKI rates after EVAR?
Large registry analyses, like from the Vascular Quality Initiative, VQI, have shown rates of postoperative AKI after standard EVAR around 3%, with about 0.4% of patients needing new dialysis. Importantly, developing AKI or needing dialysis after EVAR is strongly associated with significantly lower long-term survival.
What are the risk factors for AKI specifically after EVAR?
Some identified risk factors include developing new congestive heart failure after the procedure or needing to return to the operating room with the use of vasopressor medications to support blood pressure. Having better kidney function before EVAR, like a GFR 60 mmHg, seems to be protective.
How does EVAR compare to open repair in older patients?
Another VQI analysis focusing on octogenarians found that open repair was associated with a higher rate of postoperative AKI compared to EVAR in this age group. However, if AKI did occur, it led to higher 30-day mortality regardless of whether the patient had open repair or EVAR. Independent risk factors for AKI in these older patients included choosing open repair, having COPD, pre-existing chronic kidney disease, stages 3, peripheral vascular disease, a larger aneurysm diameter, and perhaps surprisingly preoperative beta blocker use.
What about the more complex endovascular repairs like fenestrated or branched grafts, FEVAR-BAVAR, for aneurysms involving the visceral arteries?
Those are challenging procedures. Compared to open surgery for similar complex aneurysms, these advanced endovascular techniques seem to be associated with lower rates of needing dialysis immediately after surgery. However, the rates of being discharged on permanent dialysis might be similar.
How does kidney function fare long-term after FEVAR compared to standard EVAR?
Studies comparing FIFO to standard EVAR have shown fairly similar gradual declines in estimated GFR over 2 and 5 years. The rates of progression to more severe chronic kidney disease, CKD stages IVV, or needing dialysis were low and similar between the groups. However, FEVAR was associated with a higher rate of developing narrowing or blockage in the renal arteries themselves over time, and consequently more need for reinterventions on the renal arteries.
So, complex endovascular repairs have their own set of renal risks.
Yes. Although the overall risk of progressing to dialysis seems relatively low in experienced centers, even if AKI occurs after FEVAR, kidney function may improve by 6 months, though maybe not fully recover by 2 years. It suggests these complex repairs, while technically demanding, can be done with acceptable renal risk by specialized teams.
Given all these risks, whether from open surgery or endovascular procedures, what specific strategies do surgeons use to try and protect kidney function during aortic surgery?
It's a multi-pronged approach, really. The absolute primary goals are always to limit the warm ischemia time, that period, without blood flow as much as possible.
Minimize clamp time.
Exactly. Also, ensuring the patient is adequately hydrated before surgery starts is crucial. Then, during the operation, meticulous replacement of any blood volume loss, avoiding repetitive or prolonged periods of ischemia if feasible, and maintaining maximal cardiac performance are all key.
Are there specific drugs or techniques used?
Yes, several other measures are often employed, though the evidence for some is stronger than others. Mannitol, an osmotic diuretic, is frequently given just before aortic clamping.
Why mannitol?
The idea is that it might help maintain urine flow, potentially attenuate the reduction in blood flow to the kidney's cortex during clamping, act as an oxygen-free radical scavenger, and maybe decrease subclinical kidney damage. However, the data supporting its definite benefit in preventing major AKI is conflicting.
What about other diuretics like furosemide, Lasix?
Furosemide might be used to try and convert an oliguric state, low urine output, to a non-oliguric state, as non-oliguric AKI generally has a better prognosis. However, forcing urine output with diuretics doesn't necessarily mean kidney function itself is improving, and it needs careful fluid management alongside it.
And cooling the kidneys. Renal hypothermia.
Yes, that's another strategy, especially for complex suprarenal or orgo-abdominal repairs. It involves infusing cold crystalloid solution either into an isolated segment of the aorta that includes the renal arteries, or sometimes directly into the renal artery openings. Even moderate cooling provides significant protection against ischemic injury. The first 10 degrees Celsius drop in tissue temperature seems to provide the greatest benefit.
Any other drugs used for protection? Low-dose dopamine.
Low-dose renal dose dopamine was used historically
Oh.
based on the idea it selectively dilated renal arteries. However, large clinical trials failed to show a proven clinical benefit in preventing or treating AKI during aortic surgery or other critical illnesses. Plus, dopamine can have side effects like heart rhythm problems or even worsen blood flow to the gut. So it's generally not recommended anymore for renal protection.
What about phenyldopam?
Phenyldopam is a selective dopamine 1 receptor agonist. It does increase renal blood flow and GFR in healthy people and has shown some promise in animal models of contrast nephropathy. Its specific role and benefit during aortic surgery haven't been clearly established yet through large trials.
And ANP, atrial natriuretic peptide.
ANP, being a vasodilator and diuretic, has also been studied. Both ANP and phenyldopam have shown some benefit in preventing CMIN and perhaps renal dysfunction after cardiac surgery, but again, their role specifically in aortic surgery remains unclear.
You mentioned distal aortic perfusion for TAAA repairs earlier.
Right, that's a technique where blood flow is maintained to the lower body, including potentially the kidneys, during the time the aorta is clamped higher up. This can be done using bypass circuits. Sometimes special octopus catheters are used to directly perfuse the renal arteries during the clamp time.
Does that always help the kidneys?
It's complex. While it can protect the spinal cord, some studies suggest that routine use of distal perfusion, especially in extensive TAA repairs like type 2, might paradoxically be associated with increased risk of AKI. So it's used selectively, and other renal protection strategies are often combined with it.
What about surgical technique itself?
Yes, careful technique is important. Avoiding repetitive aortic cross-clamping can help minimize microembolization, showering of debris. In patients with significant plaque buildup around the renal arteries, sometimes surgeons might temporarily clamp the renal arteries themselves before applying the main aortic clamp to prevent debris from being dislodged directly into the kidneys.
And that left renal vein division you mentioned.
Sometimes, dividing the left renal vein where it crosses over the aorta is necessary to get adequate surgical exposure for a high aortic repair. It's generally thought to be safe because the left kidney usually has extensive collateral venous drainage pathways through other veins, like the gonadal, adrenal, lumbar veins. Reconstruction isn't commonly performed. However, studies looking at the long-term impact on kidney function have shown conflicting results, so surgeons try to preserve it if possible, or at least preserve its major tributaries.
Wow, it really is an intricate field, constantly trying to balance the surgical needs with protecting these vital organs. If, despite all these efforts, acute renal failure does occur after vascular surgery, how is it managed medically?
Okay, so acute kidney injury, or AKI, is defined by a rapid decline in GFR over hours to weeks, severe enough that the kidneys can't adequately clear waste products. Urine volume can be variable, sometimes low, sometimes normal. The causes, as we've discussed, are typically related to tubular damage, like ATN, or vascular issues.
Are there specific classification systems?
Yes, modern classification systems like KDIGO, or AKIN, are used to stage the severity of AKI, replacing older criteria like Rifle-E. Importantly, increasing severity of AKI is directly linked to a higher risk of death.
What's the first approach to management?
The immediate focus is on correcting any life-threatening imbalances in fluids, electrolytes, and the body's metabolic state. The textbook provides detailed tables outlining management, but essentially it involves carefully managing fluid intake and output, correcting electrolyte abnormalities like high potassium, hyperkalemia, or low sodium, hyponatremia, treating metabolic acidosis, excess acid in the blood, and managing phosphate levels. Nutritional support is also crucial.
What if the kidney function continues to decline towards needing long-term support?
If AKI progresses to more established chronic kidney disease, CKD, or if a patient with pre-existing CKD worsens significantly, management focuses on slowing further progression and managing complications. This includes things like restricting dietary phosphate, using phosphate-binding medications, managing calcium and vitamin D levels to prevent bone disease, treating anemia, often with iron and erythropoiesis-stimulating agents, and ensuring appropriate vaccinations, like for hepatitis B. As GFR drops towards the 15-20 mmol range, discussions about renal replacement therapy, dialysis, or kidney transplantation need to begin.
The textbook mentioned an algorithm for evaluating postoperative kidney problems.
Yes, it typically outlines a stepwise approach. First, rule out postrenal obstruction like a blocked catheter. Then, assess volume status and cardiac function to address prerenal causes. If those are excluded or corrected and kidney function doesn't improve, then intrinsic renal damage, parenchymal causes like ATN, becomes the primary concern, often requiring supportive care and potentially dialysis.
And finally, dialysis itself. We hear about it often, but what are the main types used in these situations?
Dialysis becomes necessary when the kidneys fail, to the point where supportive measures aren't enough to control fluid overload, electrolyte imbalances, or the buildup of uremic toxins. A huge number of people in the U.S. require dialysis or transplantation. Unfortunately, even with dialysis, annual mortality for patients remains high, around 15–25%.
What's the most common type? Hemodialysis.
Yes, hemodialysis HD is very common. The basic goal is to safely pump the patient's blood through an artificial kidney, the dialyzer, where waste products diffuse out into a special fluid called dialysate, and excess fluid is removed.
How is the effectiveness measured?
The dose of dialysis delivered is often measured by a parameter called KTV, which considers the dialyzer's efficiency, blood flow rate, dialysis time, and patient factors. There are specific targets for KTV to ensure adequate clearance.
Are there other methods besides standard hemodialysis?
Yes. Ultrafiltration and hemofiltration are techniques primarily focused on removing large volumes of fluid, with less emphasis on clearing small waste products. These are often used in the intensive care unit for managing acute fluid overload in patients with AKI after major surgery. They can be done continuously.
Like CVVH.
Exactly. Techniques like slow, continuous venovenous hemofiltration, CVVH, sometimes with added dialysis, CVVHDF, or older arteriovenous methods, CAVH, CAVHDF, allow for gentler, continuous fluid and solute removal in critically ill patients who might not tolerate standard intermittent hemodialysis well.
And peritoneal dialysis.
Peritoneal dialysis, PD, is another option, more often used for chronic kidney failure, but sometimes acutely. It uses the patient's own peritoneal membrane, the lining of the abdominal cavity, as the dialysis filter. Sterile dialysis fluid is instilled into the abdomen, dwells for a period, and then drained out. It's a slower, gentler process and avoids the need for vascular access, but it's not suitable for everyone, especially after recent abdominal surgery or if there are specific contraindications.
So a range of options depending on the clinical situation.
Correct. Tailored to the patient's needs.
Wow. So from the incredible microscopic workings of the nephron, filtering hundreds of liters a day, to the immense challenges of protecting kidney function during major vascular surgery and managing failure when it occurs, it's just abundantly clear how critical these organs are and how deeply interconnected their health is with our vascular system.
Absolutely. That initial statistic about the sheer volume of plasma filtered daily is staggering, isn't it? It really puts into perspective how interventions on our blood vessels, whether it's clamping the aorta or injecting contrast dye, can pose such significant challenges to this delicate system.
What really stands out to me is both the incredible resilience and the delicate balance of kidney function. It's amazing how it adapts, but also how vulnerable it can be to disruption from so many factors, from tiny hormonal signals right up to the major physiological stress of surgery.
Exactly. It underscores how everything in the body truly is connected. The kidneys aren't just isolated filters. They're constantly responding to and influencing cardiovascular health, fluid balance, electrolytes, the whole internal environment.
Yeah. For you listening, I really hope this deep dive has shed some light on this vital, maybe often overlooked, relationship between your kidneys and your vascular system. Perhaps some of the terms or concepts we've touched on, like, the RAS system or the strategies for preventing contrast nephropathy, might be something you find interesting enough to explore a bit further on your own.
And that really brings us to a final, broader point for you to consider. Given this deep, intricate, and sometimes precarious interplay between our vascular system and the function of our kidneys, what wider implications does this have for how we should think about approaching our overall health, particularly as we get older? How does understanding this connection inform a more holistic view of staying well?